background. First, we want to thank people that were here, and we want to thank Hilltop. For some background, CRSP actually partnered with a few vendors over the past year to evaluate specific aspects of the Maryland total cost of care model and some care transformation initiatives throughout the state. Hilltop was actually selected with a vendor defined project. So they actually brought to us this wonderful analysis and idea, and over the past couple of months have researched and created a report, including this presentation, about the need for data solutions to bridge the information gap during transitions between LTSS and acute care settings. With that, I guess I'll hand it over. So we at Hilltop, we have Dolapo Fakai and Ian Stockwell, who will be presenting today. And we'll keep this pretty, I guess, casual. So feel free if there's any questions to put them in the chat. I can keep an eye on it, and we can go from there. So Ian, Dolapo, whenever you guys are ready.
Great, thanks so much, Jessica, and hello, everyone. Thanks so much for having us. We are very excited to present our findings on LTSS care transitions. Next slide, please, Dolapo. And I'll start with just a brief overview on Hilltop Institute for those of you who haven't heard of us or don't know what we do. So we are a university research center based at UMBC. We have about 50 or so staff, and we live in this kind of middle ground between academic research and healthcare operations. And it's an exciting place to be, as you can imagine, because on the university side, we have access to a ton of wonderful faculty and PhD students who care deeply about both the implementation of technology and the use of data in decision-making, as well as how do we make the world better, right? We know that we have a healthcare system in our country that can serve the luckiest of us fairly well, but leaves a lot to be desired. And one of our roles within the university setting is to try and fix that, right? How do we use the data and technology solutions that are available in a way that we can enhance the care, especially for those most vulnerable populations. Next slide, please, Dolapo. All right, so here's our mission statement. We've been around for going on 30 years now, and so we've gone through a few iterations of really what our mission is, right? And again, it's kind of trying to bridge this gap between the academic research world and the operations world. So my name's Ian. I'm the chief data scientist of Hilltop and faculty member of UMBC. And one thing that I have noticed over and over again through the years is that most faculty members, they have their niche and their focus area, and what they want more than anything is to apply that in the real world. And yet, for a lot of academic institutions, especially those not at a teaching hospital, like there isn't all that much opportunity to do that application. And so Hilltop's, what I think one of our main roles is to give faculty that opportunity, and specifically for the populations that need help the most. And so when we get to the pitch that we made to CRSP on what we wanted to solve, hopefully you'll agree that we picked a population that could use some help. Next slide. So in addition to doing the academic research, doing the healthcare operations, giving researchers the ability to apply their ideas, core to our mission as a research center at UMBC, which is part of the University of Maryland, is service to the state, right? So our outgoing president, Dr. Freeman Rubowski, says every time we hear him speak. UMBC is a public university, and one of our focuses is public service. We're a public university, want to serve our state, which makes sense, right? Like that is a role of a public institution, in addition to one that, quite frankly, like has state budgetary line. And so we take that very seriously, and through everything that we do, engage scholarship on the academic side, policy and data analytics on the operations side, expanding outside of Maryland. We want everything to come back to make the healthcare system in our state as good as it can be. Next slide. All right, so as Jessica mentioned, we, as Hilltop, responded to an RFP that Chris put out in 2020. And I will have to say that I've been part of a lot of RFP responses. And this was by far my favorite, because it basically said, like, hey, what do you think we should fund you to do? And we had many, many ideas. And what we picked was one that focuses on this intersection of populations that Hilltop has tremendous expertise in. So we do a lot of work with the Medicaid population. We do a lot of work with the Medicare population. Individuals who are covered under both programs are known as dually eligible individuals. And by and large, they are fairly high acuity, fairly low income, high social need individuals who often are also using long-term services and supports, which is another focus area of Hilltop. Right. So what we picked was this group of dually eligible individuals receiving long-term care, either at home or in an institution, in a nursing home. And what we wanted to see was one of our other focus areas is predictive modeling. Can we develop a very succinct predictive model for these individuals to identify an adverse health event? Right. So Hilltop has multiple predictive models out in production and operational spaces, both on the Medicare and Medicaid side, but nothing specific to this high need, low resourced long-term care population for whom we have a bunch of data that we don't have on other people, but for whose care transitions are often poorly managed. So that's what we pitched, and Chris graciously accepted our proposal, and we'd like to tell you what we found. Next slide. And with that, I'm going to hand it over to my colleague, Dr. Dolapo-Fakai, and then I'll come back at the end and we'll hopefully answer some of your questions.
Thanks, Ian. Hope everyone can hear me clearly.
Yep, sound good.
Excellent. Thank you, Ian. And thanks to everyone for joining as well. As Ian mentioned, my name is Dolapo-Fakai. I'm a principal policy analyst here at Hilltop. And I've been working with Ian and a few other members of our team on developing this project since July of last year, I believe, when we started the engagement with CRISP. And at this point, I also just want to join Ian in saying thank you very much to the CRISP team, and also to Nate from HMetrics, and to William Henderson from CRISP as well, from HSCRC, forgive me. Throughout the process with Jess and Megan and other members of the CRISP team, they gave good guidance and good feedback all along the way. So this project is as much their work as ours as well. But as Ian mentioned, I'll be just walking you through main research findings, going into a little bit of detail on the methodology we applied, as well as the results that we found. But at any point, if there are any questions along the way, please feel free to raise your hand or type a question in the chat, or to ask the question directly. Yeah, so the main problem statement, as Ian kind of overviewed, was related to the transitions of dually eligible beneficiaries in Maryland, and specifically transitions between acute care settings and the long-term services and support settings. So essentially, we're looking at these transitions for 2 years, 2 fiscal years. And just from the literature and as a background, these transitions are typically very complex, especially for population as duals who might have more admissions and more encounters with the medical care system than other healthier beneficiaries. So when these transitions occur, there are two main factors that kind of increase the risk of adverse outcomes. So there's a transition between institutions from acute care settings to the long-term settings and vice versa. And there's also the transition in coverage or between payers. And so when these happen, there is just there's a gap, an information gap that occurs because not all the information that each setting needs is communicated across that transfer. So important patient data on risk factors for readmission, for adverse outcomes, sometimes are not well connected across that transfer. So we think that there's a certain role CRISP can play, especially with the efficient health information exchange that they do already for ADTs, so admissions, discharges, and transfers from hospitals. We thought that since CRISP has really perfected that process, this could be applied as well to these transitions, specifically to get data to acute care providers on some of the characteristics of these patients from long-term care settings, so that there's more seamless transfer of information. So yeah, the solution that we proposed was just to kind of close this information gap. We thought would really help to improve safety of these transitions. And what we envisioned as the initial proposal was a data portal that would obtain information from the long-term care setting for duals, specifically information related to their behavioral health status, their functional limitations, and their cognitive capacities. We thought if a portal could be created that would get the latest information on these characteristics for a beneficiary at the point of admission to the hospital, that it would communicate important information to the care providers in that acute care setting so that they can better plan for the care of the patient in the hospital, better manage their condition in the hospital, and also on the back end, as the patient is being discharged, if there are potentially any new conditions or new medications or new management directions for their conditions, that information could also be transferred to the long-term services and supports provider so that they have the most up-to-date information to manage the patient upon discharge and hopefully prevent a readmission. So we envision that portal, that data sharing portal, on both ends of the transfer. And this study specifically focused on the first part of that transfer. So when patients are going into the hospital, what information can we get from the long-term services and support setting that might be helpful to acute care providers in the hospital? The way we framed the studies were typically with two research aims. So the first was to even understand what the scale or the magnitude of these transitions are. We tried to do an epidemiological study that looked at the number of cases that this potential portal would be handling on an annual basis, for example. So the first question was, what is the scale of these transfers that occur for this population in Maryland? And then the second part of the research aim was looking at the elements that we can abstract from patients in the long-term services and support setting. There is a wealth of information from those assessments that take place on those patients periodically. So we wanted to, in creating this portal, we didn't want to just feed it with all the information from all the assessments and make it overwhelming. But we thought if we could identify a few elements that are fundamentally associated with the risk of readmissions, we could streamline those elements, and maybe those could be the ones that CRISP or a potential entity could focus on in terms of abstracting this information on the patients and making it available to acute care providers. So the second part was trying to identify which are those fundamental elements that pose the greatest risk for adverse outcomes. And regarding study design, so we limited our analytic sample to full benefit duals in Maryland who enrolled during 2 fiscal years, fiscal year 2019, which runs from July 2018 to June 2019, and then the following fiscal year, which begins in July of 2019 and ends in June 2020. So we looked at data from those 2 fiscal years, which were the latest available. And for data sources, we looked at primarily 4 of them. So we looked in the Medicare central claim line feeds, so Medicare claims, essentially to be able to document these inpatient encounters. So for people who are fully covered for benefits on Medicare and Medicaid, when they go into the hospital, would have their Part A claims for inpatient stays, which we could get from Medicare. And then since they're also fully covered by Maryland Medicaid as well, that was our link for the MMIS. So that's the Maryland Medicaid Information System. We could look at these for these dual beneficiaries. We could also look at their Medicaid claims using MMIS as a link between the CCLF and the long-term services and supports that are supported by Medicaid. So we linked data on each person from Medicare to MMIS. MMIS gave us information on the beneficiaries' eligibility, providers they saw, and also if they had claims for a long-term services and support setting, which for this study could either be a nursing facility claim or could be home and community-based services that are sponsored by Medicaid. So we have those 2 data sources. Once we establish that linkage, we could also look directly at the home care assessments that these individuals who were receiving HCBS claims were administered over the study period. So that's the link to the LTSS Maryland in the 3rd bullet. So they have an assessment. It's called the Interi Home Care, or Interi HC. It's a standardized, validated assessment of the home care environment, home care services and supports that patients receive, as well as the quality of care, quality of the living environment. It has about, I think, 12 modules that just really assess the patient and the environment. And we chose to focus on the items that were discussing the functional, cognitive, and behavioral characteristics of the patient on the HCBS side. And also for patients who were being admitted to the hospital from nursing homes, we used the minimum data set, or MDS, as the assessment of interest. It's pretty similar to the LTSS Interi Home Care as well. So there's data on the functional, cognitive, and behavioral characteristics of the patient, but this is exclusively for nursing home residents. So both the Interi HC and the MDS are administered periodically to the patients, but also when there are significant changes in the care protocol or conditions or disease status of the beneficiaries as well. So we're able to get, for a patient who had multiple administrations of these assessments, we're able to get their latest one as a good proxy of the cognitive, behavioral, and functional characteristics of the patient right up until the point they were admitted to the hospital. So the main study procedures we went to are outlined in this slide. The first step was to define what these hospital episodes were. And essentially, once we defined them, to see which of the beneficiaries in our study sample also had repeated encounters, which means they went back to the hospital within 30 days. So the way we defined the hospital episodes were from the Medicare claims, and the claims as they are in the data set are for each service or for each date of encounter. So what we tried to do was to group the claims together into an episode of care, which used successive claims that were separated by less than a calendar day. So if a patient had claims on a certain day, had another claim for an inpatient service on the following day, we would group those together as the same episode or same stay. But when those claims were separated by more than one calendar day, so it could be 2 days or greater, we separated those as two distinct episodes. And these hospital episodes, we grouped them, I guess, more comprehensively. So not just only inpatient admissions, but ED visits as well as observation stays. So we used a broader category that just went beyond inpatient admissions for defining the episodes. So after we defined the episodes and then also identified instances where the patient returned to the hospital setting, at least within 30 days as a measure of readmission, or what we call repeat hospital episodes. The next step was to see for these admitted patients, what setting they were coming in from. So what long-term services and support setting they were coming in from before admission. So for that, we did a retrospective look back for each admission and checked if in the previous year before the patient went into the hospital, if they'd received Medicaid-funded nursing facility or home and community-based services claims. So looking back from that date of admission, we'd see if there was any nursing facility claim or HCBS claim by Medicaid. And based on the most recent claim for patients who maybe have had both services, we're able to define their pre-episode setting as the most recent of those claims. So if the most recent claim was from a nursing home, we assign that setting as the pre-episode setting for the patient. Or if it was from a home and community-based service claim, then that was assigned as a setting as well. So each patient just had one pre-episode setting based on their most recent LTSS claim. Then the next step after defining the setting was to characterize these patients based on their behavioral status, cognition, and function. And so for that, we used their most recent assessment based on the pre-episode setting. So this was actually a bit more challenging than we thought, because patients could either be admitted from the nursing home pre-episode setting or from the long-term services, from the HCBS episode setting, forgive me. Since there were those two options, and each setting also had a different assessment. So for the nursing home patients, we had the MDS. For the HCBS patients, we have the NRI. The first step we had to do to make things uniform across both settings was to link these assessments. So the NRI assessment for the HCBS and the MDS assessment for the nursing homes, those are two distinct instruments. So the first step was to at least link them both in terms of common questions, so that we can have the same question and response theoretically for each patient, depending on whatever setting they were emerging from into the hospital. So the first step was to see which items related to behavior, cognition, and function were related between both instruments. And we're able to match 21 items across these three domains between the two instruments. And these items were ones that had very similar questions, very similar response scales as well, very similar recall periods, so that we felt confident that they were essentially asking the same thing, regardless of what setting the patient was. So we were able to successfully match 21 of these items across the three domains. And we use these as our characteristics for beneficiaries who are going through these transitions. And so once we identified and were able to link these items across the questionnaires, the last part of our analysis was then trying to see which of these 21 items are actually significantly associated with the outcome of having a repeat hospital episode. And so for that purpose, we used multivariable logistic regression on the outcome of experiencing the repeat episode as a function of all of these different items to see which ones were significantly associated with the outcome. All right, so jumping into the results. So we identified a very high number of hospital episodes across both years, about 130,000, and among about 41,000 dually eligible beneficiaries. And it's important to note, we'll show us a graph on the very next slide, that study period also included the beginning months of the pandemic. So there was some reduction, as you see in the following slide, in the count of episodes dating from about March of 2020 till the end of the study period. But among the episodes that we saw, there were about a third of them were inpatient admissions. The majority of them were outpatient ED visits, where the patient went to the ED but was not admitted for a subsequent inpatient stay. And then a very small proportion were observation stays. The average length of stay was for the inpatient admissions was about 9 days, with a median of 6 days. Most patients were female, non-white, older than 60 years at admission. So we had sort of a split between people who were older than 60 years and people who were younger than 60 years. And most were in the Medicaid coverage group for SSI recipients. And most of the prevalent principal diagnoses were sepsis, urinary tract infections, chest pain, and chronic obstructive pulmonary disorder. Yeah, so this is the graph I mentioned, just showing the monthly trend of these episodes across the 2-year study period. And as you can see, in the very blue line, the top blue line is the total count of all those episodes across inpatient, ED, and observation stays. The yellow line is the ED stays, and the orange line at the bottom is the inpatient stays. Just looking at the trend of those lines across the time, you can see that the trend is typically stable up until the point where we get to about February of 2020, which is the peak right before you see a steep decline in the total as well as in the ED visits as well. Inpatient visits decreased, but not to the extent that we saw with ED stays. And of course, since ED stays form about 68% of the total blue line also shows that very steep decline that mirrors the ED trend. So we did note as a limitation that the count of episodes that we saw may not be really representative of previous years or future years, just based on the impact of the pandemic towards the tail end of the study period. And to dive in more into the repeat hospital episodes, what we saw was that out of the about 130,000 episodes that we mapped in total, there were about 38,780 where the patient returned to the hospital for an inpatient stay, for an ED stay, or for an observation stay within 30 days of the index admission. So that repeat rate was about 30%. And since people are very much more familiar with inpatient to inpatient repeat episodes where what we typically call readmissions, where the patient went in for an inpatient stay and then returned within 30 days for another inpatient stay. Just to give that metric, since people are more familiar with it, for this study sample, that 30-day repeat rate was about 15%. Yeah, and we also looked at, for these repeat episodes, if the patient was returning for the same principal diagnosis as the index stay, and that rate was about 9%. So most of the repeat episodes occurred with the same provider as the index episode. And after the initial disposition of the patient was discharged to home for the index episode. So most patients were returning to the hospital from an initial discharge home. And what we saw was that there was no major difference in rates of discharge to the home or to the nursing facility following the index and the repeat episodes as well. Regarding the pre-episode setting, so where for each patient who was admitted, what their most recent setting, LTSS setting was based on their most recent nursing facility or HCBS claim. What we saw was that so within 1 year before admission, for 14% of these cases, the nursing facility was the most recent claim that they had. And for about 22%, had most recently been in an HCBS setting. So combined together, that's about 35% of the admissions that we saw in total for those episodes. So about 65% of the patients who underwent the episodes were not in nursing facility or HCBS settings prior to their admission, at least within the previous year. And just looking at a little bit more descriptive characteristics about these settings. So the median intervals from when the patient was admitted to their prior nursing facility claim was about 5 days. So the patient was in the nursing facility 5 days before admission as the median, and the relative one for HCBS was about 1 day. So essentially transitioning from the HCBS setting to the hospital episode. And in about 3/4 of those hospital episodes with the nursing facility pre-episode setting, we just tried to also look back to see if, for example, if the nursing facility claim was your most recent, we wanted to also make sure that you'd been consistently using that nursing home before the admission. So it wasn't just based on just defining the setting just based on one claim, but also to kind of see if there was some consistency in the patient using that setting before they came into the hospital. So for the patients that we defined their pre-episode setting as nursing facility, those patients had a most recent nursing facility claim, of course, but they also had a nursing home claim in at least 4 of the previous 6 months before they were admitted. So just giving more validity to that setting we assigned to the patient, that they were consistently using that setting. And for patients with HCBS as their pre-episode setting, we saw that those patients also had an HCBS claim in at least the previous 4 of the 6 months. We had about 87% of them that had used HCBS claims consistently before admission. So just giving, like I said, more validity to the setting that we assigned. And just wrapping up with the results here. So as we mentioned, we had those 21 items across the 3 domains. Those are what you see listed on this slide. And in the very rightmost column, what we mapped out are just the proportion of the index episodes that resulted in repeat episodes. What percentage of those patients had each of these characteristics? So we have the cognitive block, the behavioral block, and the functional block of characteristics. And just as you can see, we see the highest prevalence are the ones that are shaded in yellow for each box of items. So for example, cognitive impairment in daily decisions was the highest prevalence for cognitive characteristics among patients that had a repeat episode. For behavioral conditions, verbal abuse exhibited was the highest prevalence. And for functional characteristics, bathing dependence, people who had bathing dependence reported in their assessment was about 92.5%. So that was the highest for functional characteristics. And just to be sure, so the short term for each of these items, what we did was, and maybe I should give you more detail about this, typically in the assessment for each of these items, there was a response scale that is typically on what they call a Likert scale. So where the patient or the person administering the questionnaire who's assessing the patient rates the item typically on a 5-point scale from, the behavior is not exhibited to the behavior is exhibited, I guess, in the most extreme case. So what we did just for the sake of analysis was to constrain that set of responses to just a single yes, no. Where yes is that some aspect of that characteristic is exhibited, and no is no aspect of it is exhibited. So essentially the patient is independent for that need or does not exhibit that behavior. So we did that constraint of, reducing the variety of responses to a simple yes, no indicator. So that was also one of the limitations that we had to do just to keep the analysis, I guess, more not more valid, but just more manageable in terms of the modeling. So as you can see here, people who, for example, reported cognitive impairment in daily decisions was about half of the group that had a repeat episode. For bathing dependence, so those are people who said they were bathing, who did not who needed bathing assistance for based on the questionnaire. That was about 93%. So just to clarify that, that means that there was at least some dependence needed, but we did not look at the scale of dependence. So just to be sure. And finally, just the very last slide for the results here. So this table shows the results of the multivariable logistic analysis that we did. And what we did was the model outcome is a patient experiencing a repeat episode, controlling for a few demographic characteristics, as you can see at the very bottom of this slide. So including age, race, sex, the marital status, the calendar quarter they were admitted, an indicator for whether any part of that episode occurred in the ED, also an indicator for whether the patient had any prior episode within the previous 6 months. We also had accounts of the chronic conditions the patient was diagnosed with, as well as the disabilities that the patient was diagnosed with. So we controlled for a very robust set of covariates. And then we included all of these 21 characteristics as well to see which ones were significantly associated with the risk of the patient returning to the hospital. And in summary, we saw 7 characteristics that were associated with that risk. There were 4 that were positively associated. So that indicates that a patient who has that characteristic has a higher risk of the outcome of returning to the hospital. So those are the ones where the odds ratio, which is the column just right before the last one, where the odds ratio is greater than 1. So that indicates an increased risk. So the way to interpret these findings is, for example, with the first one, hearing difficulty, right in this highlighted row, a patient who reports hearing difficulty has a 10% greater odds of experiencing a repeat admission compared to a patient who did not report hearing difficulty in their assessment after you control for all these other covariates. So for a patient with similar age, similar race, similar sex, the same marital status, they were admitted around the same time, and also had previous histories that were similar. If the only difference between those 2 patients was that one reported hearing difficulty and the other did not, then the person with hearing difficulty had a 10% greater odds of being admitted for a repeat episode after a previous admission. And the same interpretation goes for patients who reported being easily distractible. It's about a 9% greater odds. Patients who reported being self-injurious on their assessments, the odds were greater by about 33%. Patients who exhibit verbal abuse as well was greater by about 15%, excuse me. And so those were the 4 characteristics that were positively associated with the outcome. We also saw 3 that were negatively associated with the outcome. So that means that patients who report those characteristics have a lower odds of being admitted to the hospital after a previous episode. So for those 3 were inappropriate public behavior. Patients who displayed this characteristic had about 38% less odds of being admitted for a repeat encounter. Similar with patients who had eating dependence and patients who had bathing dependence also had lower odds of the repeat episode, accounting for all other covariates. So those were the 7 that we saw. We did see with the other characteristics which are not in yellow, some tended closer to significance than others, but the ones in yellow are the ones that were statistically significant at the 5% level for those results. So, excuse me. And so just to summarize on what we saw, like I mentioned these before, there were some key limitations that we had with the study that we tried to address and mitigate, but that may still apply in interpreting the findings may be important. So the first is that the pandemic may have reduced the frequency of episodes and repeat episodes. As we saw with that graph trend, we did see a dip in episodes after March 2020. So that may indicate that the total count of episodes that we have may just not be representative of other years where the volume was more consistent. The other limitation is that we did not control for quality of care in hospitals or of post-discharge care where the patient was discharged to. And we acknowledge those might be important determinants of whether a patient returns to the hospital after a previous admission or not. But because of the small sample size we had for these patients, specifically those that had a repeat episode, we could not control for too many more covariates than the pretty considerable list we had already. So we opted not to include any fixed effects for hospitals or for nursing facilities, but that could probably be done with a much more larger extensive study. And finally, as I explained, the responses to these assessments were more varied than we presented. So we presented them just as binary indicators where the patient either had the characteristics or not. But in actual fact, those responses were more varied because we did have measures for the degree of impairment or the degree of independence that patients had with each of these characteristics. But for the modeling, it was just much more manageable to have them as binary indicators. And so I'll just wrap up with these major conclusions. So what we saw from this study was that data from LTSS assessments, specifically the MDS for nursing homes and the NRI-HC for HCBS recipients, they do contribute important information to evaluating the risk of adverse outcomes after a patient is hospitalized. So for patients who undergo these transfers between acute care settings like hospitals and LTSS settings, either in the community or in a nursing home, these assessments actually have important information that is currently not shared across both settings. And specifically, we identified 4 characteristics from the assessments that increase the likelihood of repeated hospital encounters. And we had also identified 3 characteristics that reduce the likelihood of repeated hospital encounters, at least in our analytic sample. So that information is readily available, and we think it's really important to be able to make this information accessible to acute care providers as well, because they do contribute important information to managing these patients and preventing negative outcomes for them after they're discharged. So in conclusion, the findings we think support the creation of this health information exchange portal that we envision will benefit both acute care providers as well as long-term services and supports providers, because these are relevant indicators from the assessments that are really important towards predicting the risk of readmission. And we think even beyond just creating the portal to improve quality of transitional care, it can really help hospital providers to really plan for a patient's admission, to ensure the right resources and personnel are in place to cater to the patient's specific needs based on the information from their assessments. And we envision that by addressing this information gap, making this information accessible to both settings, it can also help to increase patient satisfaction if patients have reduced risk of coming back to the hospital, but also if while in the hospital, they also have those resources and personnel that are catered to the specific needs that they have. So I'll stop there, Ian. I don't know if you want to add any more insights before we take the questions.
No, Dolapo, that was fantastic. I mean, in summary, we were interested in very well-defined and high-need population. We wanted to know if there was information available outside of the normal administrative data available at the hospitals that could be helpful in managing the care for these folks. And it turns out, yes, there is. Before we do questions, I'll kind of hopefully we can frame the discussion in this way. So we are very happy with this work. As Dolapo mentioned, there were some limitations, but certainly not any that were insurmountable. And we do see this as the base upon which we're going to build in the future for our future research. So we'd love to hear not only questions about what we did and what we found, but also suggestions on where folks think we should go from here. If there are specific care gaps, especially for the dually eligible long-term care population that we can help address, we'd love to hear about that. So with that, we'll open it up for questions, comments.
I'm not seeing any questions in the chat. People obviously can feel free to unmute themselves. And we did have some people, looks like they had to drop off early as well.
Jessica, we're happy to take questions or comments by email too, either from those folks still on, or if anyone watches this after it's available online, we can take questions at any time.
That's wonderful.
And nothing for me. Thank you for the presentation. Appreciate it. Very insightful.
You're welcome.
Okay, well, with that, Ian, Delapo, thank you so much. You guys have been wonderful partners as we've gone through this, and it definitely was an area of interest with some great findings, and we will continue to have conversations about next steps. And we'll get this recording and the slides out to the people that attended, as well as post it on Chris' website for those that were not able to attend today. So with that, I guess we'll end a little bit early and thank everyone for their time. We appreciate it. And thanks again, of course, to Ian and Delapo. Appreciate it.
Thank you.
Bye.
Thank you very much.